Thank you for being here. Rainy day. We have a few hours together this morning. The first hour is going to be on ulcerative diseases. Again, we're going to talk about the approach to clinical presentations so that we can formulate a list of differential diagnosis and work up these cases so that we can come to an actual diagnosis and identify the best treatment option for our patients. So before we get started talking about diseases, let's talk about a little bit about what these lesions are so that we have some terminology. So erosions are more superficial defects of the skin. So it's basically kind of like a scratch. It's something very superficial that does not go past the basement membrane. And this is different from an ulcer, which is a deeper lesion that basically has gone past the basement membrane. And so these lesions are frequently covered by scabs, and when you remove those scabs, the lesions bleed easily. Both of these lesions are secondary. And so there is a recurrent theme in dermatology. We always want to find primary lesions, if at all possible, because that helps us to come out with a list of differential diagnosis. If you're just looking at secondary lesions, the list could be very, very long. So if I think about how an ulcer can occur, there are different mechanisms, and so that helps me to make a list of differential diagnosis. So one is, it could be self-inflicted, it could be secondary to pruritus. Another one, it could be that something happened to the blood vessel that was responsible for providing nutrients to that area of the skin, let's say like with vasculitis, and therefore that area of the skin dies, and so as a consequence you have an ulcerative lesion. So that's another mechanism by which you can have an ulcer. Another way, it could be that you have a massive infiltration of inflammatory cells or neoplastic cells, like in an allergic disease. We saw some slides yesterday of fire ant bites that can basically lead to an accumulation of eosinophils, and that kind of is damaging to the skin. But we have also seen some slides of dogs with cutaneous lymphoma that got ulcerative lesions. So anytime you have this massive accumulation of cells in the skin, that can be damaging, and that's one way also to get an ulcer. Or you can have an insult that is outside in, you know, like a chemical burn or a thermal injury. Those are all things that can obviously damage the skin and lead to an ulcer. It could also be due to metabolic diseases, and we'll talk about that. So the skin has a requirement for amino acids, fatty acids, and zinc, and when there is a deficiency, then you get necrosis in the skin, therefore an ulcer. Or you could have nodular lesions, and tomorrow we're going to have an hour just on nodular diseases, how to properly work up these cases. But when those nodules rupture, then you have a draining tract, you have ulcers, you have scabs that basically cover that ulcerated lesion. And also you could have an autoimmune disease that has as a primary lesion Ebola, but the Ebola is transient, it ruptures easily, and then you're left with an ulcer. So you can see that you can have ulcers for all kinds of reasons. So I'm going to kind of present some clinical examples on the different mechanisms, and I'm going to highlight the difference in the history and the distribution and things that can help us come out with a way to rank these diseases. So again, if you can find primary lesions on your patient, that will dramatically help you to narrow down the list of diseases that you could consider. And then, once again, these are recurrent themes. The sentiment is important. Is a young patient, an old patient? What is the distribution of the lesions? Is the patient itchy? Is just one specific area of the body that is affected, or is more generalized? How that is progressing over time, is an acute onset, chronic. These are all things that can kind of help to rank the list of differential diagnosis. So let's get started and let's look at some examples of ulcerative diseases in dogs. So I'm going to start with a simple one. So it's self-inflicted. So hot spots, right? We've all seen those dogs that demolish their face, and in no time they kind of create this erosive ulcerative lesions, very common in allergic dogs, particularly when the climate is hot, humid. Dogs that have a thick coat are prone to that. And the classic area is on the side of the face, but not always there. And as a clinician, you know, I need to start looking for a reason. You know, do they have an ear infection? Are they flea allergic? Do they have parasites that can justify why suddenly they get so incredibly itchy to cause those lesions? Many of these patients are flea allergic, so the rump is a preferred location, and many of them have a thick coat. You know, so like in this case, you have a Shepherd, San Bernard, so hot, humid climate will lead to this type of reaction in those dogs. So these lesions occur quickly, and they can be actually quite extensive once you start clipping and you see the extent of the lesion. So hot spots are a form of surface pyoderma. So some of these dogs have superficial pyoderma, so they have folliculitis with it, but many of them just have surface pyoderma. So many of them they don't need an antibiotic, but just they need to have the lesion cleaned, and we need to have some fast-acting drugs to stop the itch. So the last hour today, I'm going to talk about pruritus, and I'm going to talk about the treatment options to stop itch, and I'm going to compare and contrast the various options that we have so that we can pick effectively. But as of now, the fastest options you have to stop itch is either good old steroids or Apoquel. Okay, those are the fastest based on clinical trials. Now, another example of ulcerative diseases is this syndrome in cats. And so again, cats can demolish themselves because they are allergic, right? So, but this is a different syndrome. This is a syndrome that is poorly understood and that is linked to an altered sensation in the skin itself. And so you may come across these cats that for no good reason, they develop this ulcerative lesions, and the location is classic. It's typically between the shoulder blades or on their dorsal neck. And so as a clinician, the first thing to figure out is it an allergic cat? Is it possible that it kind of did it because it's allergic and itchy? Or is maybe a topical product was applied in the area that somehow caused that irritation? But if I don't have any of that, I may be dealing just with this idiopathic ulcerative disease. And this is treated with topiramate. I don't know if you have this drug here, but it's a drug that is used for seizures. So people have used gabapentin with poor success. Steroids also typically don't work. But for some reason, topiramate helped these animals, and so it's something to keep in the back of your mind. Another very common presentation of ulcerative lesions is acroleг granuloma, right? So in the practice, we have all seen these dogs. They're basically working on whatever area on their leg, and they create this massive ulcerative lesions, and that can be a manifestation of either itch or pain. right? So we don't know why the dog is incessantly focusing on that area and has that altered sensation. So it's very important to kind of think, is this an old patient that could be painful? Is this an allergic patient where I need to address an underlying allergy? As an aside, there is a drug that could address both, and that's gabapentin. So as you know, there is an overlap in the transmission of itch and pruritus, and gabapentin has been shown to be helpful either way. So that's something for us is a very cheap option that you could consider to help these patients. But one thing that I would like for you to remember is the acral leg granuloma is always secondarily infected. So if I just treat it as an itchy or a painful disease and do nothing for the bacteria, the chances of being successful are limited. So this is a form of deep pyoderma, a form of furunculosis. So I will always have to treat the pyoderma that goes with it. And as a clinician, I need to go through my list to make sure that I am looking for a reason. Before I call that dog crazy and put him on Prozac, I need to go through this list and make sure that I am not missing something that I could be treating, whether it's Demodex, dermatophytes, allergies. Many of these dogs are flea allergic dogs. Some are hypothyroid dogs. So I need to kind of, based on the sentiment, figure out what could fit my patient and make sure that I don't miss one of those things. Before I conclude that it's just like an idiopathic leg granuloma. And then treat the infection, right? So these lesions are very pruritic and it really significantly affect the quality of life of these dogs. I have had good success with acupuncture for some of these patients, and I encourage you to give it a try with gabapentin. Okay, always also consider an antibiotic, and I encourage you to have a prolonged antibiotic course. I know we're all afraid of using antibiotics for too long, but many of these patients will require a couple months of antibiotic to really have an effective treatment of that deep infection. Now, it's very important also as a clinician to understand that there are things that look like a leg granuloma, but is not. So in Florida, and I suspect here too, you have Pythium as a possible infectious organism, or Lagenidium. These are oomyces. These are not true fungi, and they are plant parasites. So you find them in standing water. So this weather is perfect for it. You know, heavy rain, lots of vegetation, and if the dog has a little cut, and then this organisms can establish an infection. Both the leg granuloma and the Pythium case are very itchy. So what's the difference? The leg granuloma has been going on for a while. Okay, so it's not this acute onset. And when I do my cytology, it's primarily neutrophils. The Pythium dog is primarily eosinophils, and the course of the disease is very acute. So they are causing these lesions in basically no time. In a week time, 2 weeks time, they have this hemorrhagic, oozing, intensely itchy lesions on their legs or wherever the infection has occurred. So it's very important to keep that in mind. Now we're moving to a different type of disease. Let's say that some primary insult occurred to the skin. And let's start with vasculitis. We already talked a little bit about that yesterday. We talk some more now. Vasculitis is a type 3 hypersensitivity, so antigen-antibody immunocomplex deposition, right? So, and this can be triggered by a bunch of different things. So saying that my patient has vasculitis is a starting point, but then as a clinician, I need to figure out why. Is it drugs? Is this an infection? Is this cancer? Is this a vaccine? What is it that triggered this type of hypersensitivity? And that that is critical so that if I can identify a trigger beside treating the vasculitis symptomatically. If you catch these cases early, you may see the early lesions like this one. In this case, if somebody showed me a slide like this, I would say could also be erythema multiforme, right? So you have these macular lesions and so on. But when I see cases that have gone on for longer, then I start having this hemorrhagic type lesions, right? And I know that whoever was in the workshop, you learned about dioscopy, to press on the lesions, do they blanch, do they not? These do not, right? Because you have a hemorrhagic purpuric lesion. And then, of course, depending on the vessels that are being affected, the lesions can be widespread, particularly if the deep vessels are being affected. And the feet are a common area to look for clues. Again, it's typically the center of each pad that has this like nice little ulcers. There's nothing like vasculitis that will cause that. So at least that's an easy way to kind of have an answer. Tip of the ears, by the way, probably you already know this, but itraconazole at high doses has been reported to cause vasculitis. This dog developed vasculitis secondary to a treatment with high doses of itraconazole. And then you can have, of course, vasculitis for all kinds of reasons, tick-borne diseases, like I said, vaccines. You can have autoimmune diseases. If you think about systemic lupus, you know, you have different kinds of hypersensitivities, type 2, type 3, but vasculitis is a common component of the pathogenesis of SLE. And so skin-wise, we see vasculitis. And depending on what vessel has been affected, the lesions can be quite deep, particularly if the vessel is a deep, large vessel. It can be on the face, not just on the feet, but the tip of the ears is a classic one. This dog was diagnosed with a carcinoma, so his vasculitis was paraneoplastic. So that's, again, important to look for triggers. Don't just stop and say, okay, vasculitis. This one had a rabies vaccine. We talked about that yesterday. And so rabies is a notorious trigger for vasculitis, particularly small breed dogs. But again, the cause can be multiple. So as a clinician, you review the records and think about what could fit the history of your patient. Another vaccine, Bordetella, that can cause vasculitis. And so with this dog, we kind of like did a short course of higher doses of steroids and some pentoxifylline, you know, and then they said, stay away from this vaccine, you know, get a different one. Okay, so I don't know what in the vaccine causes this, whether it's the adjuvant or I couldn't tell you. All I know is that it's important to diagnose this so that we can avoid new reactions when the dog is due for a booster. But this one just got cephalexin. So, you know, something as benign like cephalexin can cause that. But I've seen pemphigus induced by cephalexin, and this dog just had a 1 foot, you know, that basically got that insult, and that was a one-time thing. And then we put him on steroids and pentoxifylline, and then said, okay, stay away from anything that is cephalosporin type drug, just for lack of, you know, better understanding of how to help him. But that was an acute onset. But topical products are not any safer. I mean, you can have issues with anything, right? So this one was Advantage, which, you know, with millions of dogs on Advantage, and they don't get any problem. But here and there, you may have some that has an issue. Now, a different syndrome is this Alabama rot. And this is something that has been reported in the literature. Hopefully, you'll never see it. Is basically greyhounds that have been kind of reported more prone to it, and initially was thought to be linked to a toxin from E. coli, And these dogs get vasculitis, and it's both cutaneous and kidney. So they can get very sick, and mortality, if left untreated, can be high. So there are a couple of reports in the literature, and I've not seen anything recently. Initially was thought to be associated with feeding raw meat. But the point is there is a similar syndrome in human medicine that basically seems to closely mimic this condition in dogs. We don't really know exactly the pathogenesis of this disease, but if you come across a dog that has vascular disease both in the skin and has renal problems, again, work them out for, potentially autoimmune diseases, this and that, but also keep this syndrome in mind. And of course, the lesions can be pretty impressive because they have these thrombotic events in the skin and lots of bleeding. We talked about the nasal arteritis yesterday, right? When we talked about facial diseases, and this is an immune-mediated attack of the arteries, and the nose is frequently affected. And it's very classic. Once you see that, a few pictures, you kind of like it is very, very peculiar. Then you can have ischemic vasculopathy. So the vasculitis I showed you is acute, inflammatory, angry looking, right? But you can also have this ischemic vasculopathy that is not so aggressive, and again, frequently linked to vaccinations, and but it looks more like a dermatomyositis, right? So remember yesterday we talked about dermatomyositis as a genetically inherited disease of Shelties, Collies. Well, this is not a Sheltie, right? So he's a child, but he just got a rabies vaccine and he developed this ischemic dermatitis. So again, just something to consider. So how long can I consider something to be a possible trigger? Personally, I ask people, to kind of go back 4 to 6 weeks prior to the development of the lesions, if there was anything that was given to the animal that could potentially be a trigger. So as a clinician, we want to address the underlying cause if at all possible. And then, like I mentioned, pentoxifylline and steroids. Some people use now Apoquel as a substitution for the steroids. And there are many reports in the literature to show that Apoquel can be helpful for vasculitis at 0.6 milligram per kilogram twice daily. Now, pentoxifylline takes 2 to 3 weeks to kick in. So if I have an acute case, typically you have to start 2 drugs at the same time, whether it's your steroid or Apoquel plus the pentoxy. And then for the first 2 weeks is, let's say, the steroid or the Apoquel that gives you the benefit. And then eventually you wean them off of that and the pentoxifylline stays. And so the pentoxifylline has had enough time to start working. Now let's look at another mechanism for ulcer, which is the accumulation of inflammatory cells. So we talked about eosinophilic diseases when we talked about the cat with mosquito hypersensitivity. Dogs can also get eosinophilic furunculosis when they stick their nose in fire ants. And again, this was a case that I saw where both dogs in the same house, I guess they were outside playing together and they both got it. So obviously they were kind of sticking their nose and they got bites, both of them. And so it's painful and pruritic at the same time. And steroids, there's nothing like steroids. Anytime you have heavily eosinophilic diseases, steroids are typically very, very beneficial to kind of halt the damage of the skin, because otherwise, if left untreated, all this tissue becomes necrotic. But then you can also have examples where the cell that is involved is neutrophils, and so pyoderma, what a wonderful example for that, right? So we talked about mucocutaneous pyoderma yesterday. Well, you can have erosive, ulcerative lesions with your pyoderma just because the neutrophils when they break down, they release all these proteolytic enzymes, so they demolish the skin that way. Now, I picked this picture because I wanted to make sure that you are also familiar with this syndrome. When we talk about pyoderma, we typically talk about staphylococcus, right? So that's the bulk of the pyoderma we see. But sometimes you can see Pseudomonas in this cases of pyoderma. And the classic scenario is post-grooming follicularis furunculosis. So typically what happens is that the shampoo got contaminated, but it could also happen with a scrub. Let's say in the clinic, right, you use the same jar and you scrub multiple patients, and at some point that jar becomes contaminated with Pseudomonas, and then you are basically applying Pseudomonas on the skin, and these cases get deadly sick. It's severe follicularis furunculosis. It's painful. They can run a fever, and it's a very inflammatory, angry type of pyoderma. So it can get deep very quickly, and you need to be prompt in how you address these cases. So many of these cases end up going on fluoroquinolones because it's Pseudomonas related, and so that's something to keep in mind. And then good old German Shepherds have a very different immune system, as we all know, so they are very prone to deep pyoderma. Okay, so shepherds can easily get these deep infections, which are a combination of staphylococcus and secondary invaders like Pseudomonas, and they get these draining tracts and ulcerative lesions. Right, so we need to be aggressive. We need to culture these cases. I know you have 1 hour just on pyoderma and infections, so I encourage you not to just do trial error with antibiotics, but figure out exactly what the bacteria is, what the sensitivity is, so that you can treat them appropriately, because they need to be on antibiotic for extended periods of time. And again, so these are all examples of deep ulcerative lesions. Then we talk about nodules for a little bit. So when I see nodules, I ask myself, are they infectious or not? And they are inflammatory or neoplastic? That's the first thing that I kind of try to ask myself, right? So let's look at some examples. I'm going to start with infection. Staphylococcus, a wonderful example. We see all this furunculosis on the feet of dogs, and we have an hour on pododermatitis, so I'm going to talk a little bit more about that. But staph is a classic example of an infection. But we also have atypical mycobacteria. We see that a lot in cats. And they get this like spreading paniculitis, nodules, the draining tracts that ulcerate. And so that's another example of an infection. So where I work, I assume if I see inflammatory cells like neutrophils and macrophages, I assume infection until otherwise, because the type of climate is how it is. And so I want to make sure that I don't miss an infection, even if I don't see organisms on cytology, because with atypical mycobacteria, you will not see the organism on your diff quick. For one, they're very few. For two, they will not stain with your diff quick. So just having no evidence on your cytology doesn't mean anything. And then we already talked about Pythium as an example of an infection that can cause these nodules and draining tracts. And you may have a case that is truly a sterile paniculitis. There are some dogs that get this immune-mediated condition, and they get this waxing and waning, joint pain, and nodules that drain is typically affecting the trunk. So you could have exactly that. And we'll talk more tomorrow when we talk about nodules. But you can have also neoplastic diseases, like we talked again about mycosis fungoides, cutaneous lymphoma, where you can have these nodular lesions that will ulcerate. And so is, again, lymphoma, it can look in so many different ways. And so we always have to have it on the list if it's an older patient, so that we can think of biopsying these dogs to properly diagnose them. These are all dogs that have with lymphoma, and I just put these pictures to show you how different can look. Like some of these, they just look like angry pyoderma, right? And so again, do your cytology, treat them, but if something doesn't look right and they're not responding, it's time to take a biopsy, because they get basically these lesions that kind of simply don't heal. Again, another case of cutaneous lymphoma with ulcerative lesions. These are all dogs with lymphoma, so just keep it on your list. And some dogs, they just get sheer ulcerations, like if they had a drug eruption kind of thing, like so again, these are all different manifestations of cutaneous lymphoma. Now, other mechanism, like I said, it could be an injury outside in, right? So what are the possibilities? Could be bites, different types, or some chemical or thermal injury. So we talked about spider bites already. So there are all kinds of toxic spiders that can cause necrosis in the skin. The face is a commonly affected area because that's how they get curious and they touch and they get bite. It's very important to be aggressive and fast in your treatment with steroids so that they don't start sloughing their whole face. And they can be systemically ill. We have lots of snakes, and so obviously we got snake bites and all the draining tracts and ulcerations. Chemical burns are a way to kind of get all these ulcerative lesions if something accidentally spilled on the animal, and so you have all these necrotic injuries. But sometimes it happens in patients that have been on their back, on their heating pad, maybe for too long, and so they get these thermal burns. And so is a terrible situation for veterinarians to have these patients develop these lesions, right? And so whether it's the temperature related or it was, a vascular compromise. So those are all, possible accidents, unfortunately, that can occur. Older patients, thin patients that maybe been on steroids, like Dr. Torres showed you yesterday, so skin gets very thin, and so you can have the cubital ulcers are very hard to heal. But you could also have a vascular compromise, like a bandage that is poorly placed, like on the leg of this dog, or the other one that had this collar that was clearly too tight. So anything that damages the blood flow can then eventually lead to this type of lesions. But UV can also do that. So you can have solar damage. So the dogs that like to sunbathe, like this one, got all this solar dermatitis. So I want to show you some pictures. So you learned about comedones yesterday, right? Cushing. We think about Cushing when you see the comedones, and we think about Demodex. But another differential is actinic changes. So solar-induced changes can lead to comedones, and then, if left untreated, then you have this erosive and then ulcerative lesions. Other ways to have ulcers is, as we already discussed, if you can have immune-mediated cell necrosis, which can be individual cells in the skin that die, like erythema multiforme, or it could be if it goes untreated or is a more severe form, it can become deeper ulcerative and then eventually create lesions like this patient. If I see a picture like this, I couldn't tell you if it's vasculitis or erythema multiforme, right? Because both diseases can present very much alike. But what I do know is that I would not biopsy an ulcer. I would biopsy an area, the little macule that doesn't look that impressive, but that still has an epidermis, so that if I'm looking for EM, I am able to get my epidermis, and I can also get an early lesion of vasculitis. Okay, but then of course you can have more severe cases like toxic epidermal necrolysis where you have full thickness necrosis on the skin. This dog actually had a flea product applied, an over-the-counter flea product. So something as simple as a flea medication obviously didn't go well with this patient. And so it got this full thickness necrosis. And so it's very important to kind of provide supportive care for these patients because they're basically the equivalent of a burn patient. They lose fluids, proteins, they're prone to infections. And so the prognosis is actually guarded for these cases. Now, other options is diseases caused by a metabolic problem. So, like I said, the skin needs amino acids, and if there is an issue with that, then you have necrosis. This disease has many names over time. Pick the one that resonates with you. Some call it hepatocutaneous, some call it NME, some call it glucagonoma syndrome because in people it's associated frequently with pancreatic disease. In our patients, in dogs, it's typically liver disease, but you can see it with Cushing, you can see it with IBD, you can see it with pancreas issues. But the point is that you have a metabolic disease, and then you have deficiency of amino acids. Many of these patients, they have high glucagon levels and low albumin and low zinc. And so this is why clinically we tend to supplement these patients with zinc and fatty acids because the skin needs these critical nutrients in order to stay healthy. And so these patients in different ways, whether the trigger is a liver issues or a pancreatic issue or an absorption issue, but they become deficient in these nutrients. And so they develop these necrotic lesions. And ulcers in the genitalia area is a classic presentation for hepatocutaneous syndrome. So if I have a patient like this, I either think of some autoimmune disease or I think of some caustic, either they sat on it, or I think of NME. And how do I differentiate? Well, of course, the history, the age. So the hepatocutaneous patient is an older patient. The autoimmune patient is typically a middle-aged patient, but it's critical to differentiate between these two because the autoimmune case, I will treat it with steroids. The hepatocutaneous case should not see steroids. Many of them are borderline diabetic, and the last thing that they need is steroids. So the way to get your answer is biopsy. Biopsy an area that is not ulcerated, where you can have your epidermis and look for this classic pattern of red, white, and blue. Red is the top where you have this thick stratum corneum. White, you have this kind of like a spongiosis in the epidermis, and the blue is the hyperplasia of the basal cell layer, but it's classic, and that's what you want to see. Other mechanisms to get an ulcer are diseases that will target the basement membrane, either directly or by accident. So there are many autoimmune diseases. I'm just going to provide you some quick images of some of them, and there are publications if you want to read the specific antigen that is targeted by the virus conditions. But let's take a look at some example. One is a vesicular cutaneous lupus that basically looks very similar to erythema multiforme if you look at the lesions, right? But this is an autoimmune disease, and so again, it's important to take a biopsy looking for the specific changes, which is basically you have this death of the cells in the basal cell layer of the skin. So again, this is for the pathologist to tell you. The other one is this mucous membrane pemphigoid disease that occurs in German Shepherds, and the basement membrane is targeted as in this specific disease. And as a consequence, you have the severe ulcerative lesions around their eyes, around their mucocutaneous junctions, their anus, genitalia. And they can become pretty severe and get very sick. They have lesions in the mouth. So this, again, is a severe autoimmune disease that is diagnosed, once again, with a biopsy. Other example of autoimmune diseases that will have bulla as a primary lesion and therefore ulcerative lesions is pemphigus vulgaris, which starts in the oral cavity. Very, very important to remember. And so you have this severely ulcerative lesions, but again, the tongue, the mouth are key areas to look in these patients. And then there are other diseases, again, autoimmune diseases where the oral cavity is affected. None of these diseases is a benign disease, but they're all diagnosed with a biopsy. And if you want to attempt treatment, it's high doses of steroids to induce immunosuppression and to halt the attack of the skin by the immune system. Then you can have more benign diseases like DLE, which we already talked about a few times. So the nose is typically limited to the nose and the face, but it can be locally very aggressive. And then we talked about VKH yesterday, that basically anytime you have dogs that have facial issues as well as ocular issues, you need to think about this autoimmune disease that attacks the melanocytes. And so you need to be prompt in your diagnosis so that you can immunosuppress these patients and save their eyesight. So to summarize all this, as you can see, the list is extensive, right? So it's very important to kind of pay attention to your signalement and to the history and how things have progressed, the location of the lesion. Is the oral cavity versus the extremities? Is it slow progressive? Is it acute onset? Can I find primary lesions? Do I see bulla? Do I see nodules? Is there anything that can give me a clue of what to go after? Very important to get an accurate history about drugs and vaccines, particularly if the age of onset doesn't make sense, like if the patient is too young or too old to develop something. The average idiopathic autoimmune disease is a middle-aged individual. So if somebody is too young or too old, I look for other drugs, vaccines, or in the old one, I look for a cancer to explain why they suddenly get these lesions. Then I need to also figure out, is my patient itchy? Because if it's itchy, then I need to work him out for pruritus. And today, the last hour is going to be on how to work up pruritic patients because that is critical. And yes, you can do symptomatic treatment, but at the end, you want to have a diagnosis because all these drugs are kind of like a temporary crutch. Then you have to have a long-term plan. And again, in all these cases, cytology is critical. It can sometimes provide you with an actual diagnosis, or at times can kind of help you to decide which way to go. Is it neutrophils? Is it eosinophils? Is it macrophages? Do I see acantholytic cells? And I think about pemphigus as a possible differential diagnosis. But even just the type of inflammatory infiltrate, it kind of helps me to kind of think, if I see eos, I think fungal, I think pythium, or I think allergy, right? If I see neutrophils, macrophages, I think bacterial or other types of fungal infections, but not pythium. And then, many of these cases eventually need a biopsy. And then a biopsy, you want to biopsy, if possible, a primary lesion, and definitely avoid anything that is an ulcerated area, because that is not going to give you an answer, even if it is tempting, because those are the most severe lesions that you will see. And if you see nodules, you want to get a nodule that is not ruptured yet, and we'll talk more tomorrow. But basically, you want to kind of get the whole nodule and submit some of it for histopathology and some of it for culture. And culture, you want to ask for specific kinds of culture because the mycobacteria that I described, they don't grow in a regular aerobic culture. So it means that you need to have it as a differential diagnosis to ask for the proper type of culture. So the treatment obviously depends on your diagnosis, and so it's very important to work up these cases so that you can get to the correct diagnosis and formulate the treatment to help your patient. Okay, and know when to use the steroids. Steroids are a wonderful drug, and they can help many things, but there are a few times that you should not reach for steroids. And of the diseases I mentioned today, hepatocutaneous or NME, however you want to remember, steroids are contraindicated. These dogs need nutritional support as well as the identification of the underlying cause, but steroids is not it. Okay, so I think that you can get to the diagnosis without being a dermatologist as long as you kind of have your step-by-step approach so that you can properly diagnose and provide treatment for your patients. This is what I have for you. I have a few seconds for questions.
Test. Only it may be ulcerative or nodular type like this because there is some ulceration and nodules formation. Only the cytology shows the massive infiltration of neutrophil. There is no such bacteria, rod or cocci. There is no inflammatory neutrophils. Now, inflammatory neutrophils is there, high percentage, no bacteria, no yeast. And what that is indicates?
So things that could fit that description, other the infection is deeper, right? So that on the surface, in my experience, when the infection is deep, your surface cytology does not really give justice to what's going on. So that's one possibility. The other one is that you have maybe a contact dermatitis where you have basically an inflammatory response, but it's not due to an infection. So I think it would depend on the distribution of the lesion and the patient, how I would go about it. But if you have anything that is infiltrated lesion, I would definitely biopsy. So away from the ulcerated area and just shave the area around, feel the skin, and if there's anything that looks infiltrated, I would biopsy that. And personally, I would split that biopsy half for histopath because you want to know what disease process is going, and half of it for culture so that you can figure out if indeed there is an infectious agent. That would be my suggestion to you.
One thing is, every case cytology is showing heavy neutrophilia, heavy infestation of neutrophilia. What is the reason?
Yes, those that get this defuranculosis, they're typically big, heavy dogs, short coat, and so the bacteria are kind of like shoved in the skin so they get these deep lesions. And because when the hair follicle breaks, you have release of keratin in the dermis, it triggers this foreign body reaction, so it kind of, they create this cyst. So they get all walled off. It's an attempt of the body to kind of limit the insult. And so the cysts are basically, they started with an infection, but then even after the infection you have treated with antibiotic, the cyst stays. And so they are very frustrating cases to treat because they tend to recur. You know, you treat them and then they recur. And some of them you may actually have to excise the cyst. We do some laser with these patients once you have decreased the size of the cyst. And I typically use also some steroids to kind of decrease the inflammation and the fibrosis and so on, and I make them smaller and smaller and smaller. And when I feel like I cannot go anymore, then I surgically remove them. Because if you leave them, chances are, at least in my experience, many of them will keep recurring. But photodermatitis later this morning.
You said about acrylic granuloma and pyoderma, long-term use of antibiotic. How long? And number two, what about this PRP treatment that we see a lot? We hear a lot all of a sudden now, PRP treatment.
What
And
treatment?
PRP, platelet-rich plasma treatment.
Oh, okay.
And number three is, you said about gabapentin. What role does gabapentin play?
Yes. It's a deep pyoderma, so in my experience, you're looking at minimum 2 months. But many times they require longer depending on how big that area is, because you want the area to close, okay? So, but the general rule is typically 1 month past resolution. So if it takes you 2 months for the lesion to close, then you add 4 more weeks. So that's one. I've only done the plasma treatment in horses, never in dogs, so I don't have a direct experience to answer your second question, but I have experience with fovea. I don't know if you guys have fovea as a, no? Is a treatment that basically is to treat wounds. You kind of put a chromophore and then you apply the low light. It's a blue light, basically. And basically that improves wound healing. And so that's something that we do for this type of lesions. But I think probably regenerative therapy would work. As we do, definitely in horses, we do that. We do like stem cell and platelet enriched, injections or application. In horses, actually, we even put the serum of the patient. We have this kits, Prostride, that we use for osteoarthritis, and we kind of spin it down, and then we apply the serum that is generated by those kits, and we put it on the wound, and all these growth factors increase wound healing. So I suspect in dogs would probably be the same. And number 3 was the gabapentin, right? So gabapentin, your question was about the dose or the role? The dose? Role? So gabapentin is basically addresses both pain and pruritus. So it's thought to increase the concentration of GABA in the brain, and so it's the perception of pain and pruritus. And so it kind of modulates that, because pain and pruritus are basically, they share to some degree nerve fibers as well as mediators. And so gabapentin is used in human medicine for patients that have pruritus that is not allergic in nature. So when we think of pruritus as veterinarians, we always think of pruritus as allergic, right? So that's why we use the steroids or the Apoquel, now the Cytopoint. But basically, we are always addressing allergic pruritus. But pruritus can be also neuropathic. Okay, so because basically if you have an altered sensation in the skin, you can have the same way you can have neuropathic pain, you can have neuropathic pruritus. And then in humans, frequently there is pruritus due to metabolic diseases, whether you are in renal failure or you have uremic pruritus and things like that. So these patients don't respond to the traditional treatment for pruritus, but they do respond. There are quite a few publications. They do respond to gabapentin and pregabalin. And so basically, I tend to use gabapentin when I feel that the cause of pruritus is neuropathic. And I believe that these patients with acrylic, they have an altered sensation in their skin. And so I encourage you to give it a try. It may not work in every single patient, but I think it's a very benign thing to try. And I use 10 to 15 milligram per kilogram, 2 to 3 times a day. And you can kind of play with the dose if they get too sleepy. But it's a very safe drug. I don't know. Did I answer your question? Okay.
Sorry, sir.
No.
Running out of time.
No, the boss says no.
So, thank you, Dr. Marsella. I have a last question, just a last question. Since you said in hepatocutaneous syndrome, glucocorticoids are contraindicated, but on the day of presentation, how you approach this case, like you send the sample for amino acid detection or zinc detection, or you do the ultrasound, or you do the biopsy, like how you approach
Their patients, and I want to see if I'm somewhat in the right direction, right? So you look for, like, of course, they're, anemic, low albumin. You kind of want to see, if they have any changes in the liver enzymes and so on. So the first thing I do is I start with some blood work, basic stuff. Then, yes, we try to do ultrasound. To basically looking for the characteristic liver changes, that kind of makes you have hepatocutaneous even more on your list of differential diagnosis. And then if the owner allows, I do take a biopsy. So some people may not go for all of it, but that would be the way to start for me. And then many of them, in my experience, have yeast infections. You'll learn a lot about yeast today. But my suggestion to you is the best antifungal, if you have to pick one, fluconazole, because fluconazole is the one that has basically no liver metabolism, is excreted almost unchanged in the urine, and so would be the safest drug that you can give to these patients.